good. So good evening to everyone. Thank you, Dr. Asma, for the introduction and inviting me to talk about updates on asthma guidelines. So for the updates of the asthma guidelines, today we will be concentrating on specifically the pediatric guidelines. These will not encompass a lot of literature review, but mostly just get you to be up to date on what has been happening in the most recent guidelines. So for the objectives for the next 20 minutes will be to discuss the key points, updates and additions from particularly the 2021 GINA guideline, the Canadian Thoracic Asthma guideline of 2021, and the 2020 NAEP of the United States. So starting with the GINA 2021 guideline, we'll start with the management and we'll divide that based on the age group as it has been presented. So for the children's aged 5 years and younger, as you know, the combination of inhaled corticosteroid and formoterol is not approved for this age group yet. And hence the preferred controller reliever choice remains to be the same as a short-acting beta agonist. So short-acting beta agonist will be the main reliever to be used on a PRN basis, with the addition of controller therapy in the form of either inhaled corticosteroid or a leukotriene receptor antagonist, or what has been mentioned in a subtext embedded within the GINA guideline is the short course of intermittent corticosteroids at the onset of respiratory illness. This basically has remained the same. So for children from age 6 to 11 years of age, there have been some changes. Particularly when it came to the step 1. So children, historically, this was mainly taking short-acting beta agonist. However, now for children who have symptoms less than twice a month, they recommend taking inhaled corticosteroids whenever short-acting beta agonist is administered. This is preferred over daily inhaled corticosteroids. And that is mainly due to the poor adherence that is highly likely, particularly in this age group. Step 2 changes their tweaks a little bit. So daily inhaled corticosteroids are preferred over taking ICS on an as-needed basis with SABA, as there has been much more evidence of stronger efficacy and safety in that step. Then the addition of maintenance and reliever therapy, and you'll see that this is particularly different from the CTS guideline, where it is here recommended for 6 years and above. So this starts with the low-dose ICS formoterol, so formoterol in particular because of its short onset of action. And that is mainly because of the evidence that it reduces the risk of severe exacerbations. And we'll go a little bit into detail about the evidence behind that. Other options remain to be low-dose ICS LABA or medium-dose inhaled corticosteroids. Now, I think one of the major changes that have occurred were in the adult and adolescent age group, so for adults 12 years and above. And now it has 2 tracks. So with the 2 tracks, there are 2 reliever choices for adults and adolescents. So the first track is the preferred track, and that involves the use of low-dose inhaled corticosteroid and formoterol on an as-needed basis. And the rationale behind this is that using ICS formoterol as a reliever reduces the risk of exacerbations compared to patients using just SABA as a reliever alone. Now, the alternative track is track 2. And this involves the use of SABA as a reliever on an as-needed basis, and ICS to be taken with SABA similar to the 6 to 11 age group. So track 2 will go into why and when it can be recommended in the next slides. But let's first talk about why the track 1 is preferred for the patient for this age group. So GINA reports that because using low-dose inhaled corticosteroid and formoterol as a reliever reduces the risk of severe exacerbations. compared with regimens of just SABA as a reliever. And you'll see this coming up in most of the guidelines, that the main aim is to reduce the risk of severe exacerbations. So how is it used? So it's when a patient at any treatment step has asthma symptoms, they will use low-dose ICS formoterol in a single inhaler for symptom relief, knowing that there is a maximum amount of actuations that can be taken from a medication to another, which can differ from a country to another. In steps 3 to 5, patients also take ICS formoterol as their daily control treatment rather than just maintenance and other than just as a reliever. And this is called the maintenance and reliever therapy, or MART, or also as known as SMART in some places. So it's important to highlight, particularly for ICS formoterol, that it should not be used as the reliever in patients who are, for instance, prescribed different ICS-LABA combinations, such as serotype as their control therapy. Now, with track 2, it is recommended that patients go for track 1, but if track 1 is not possible for whatever reason, or patients prefer to be on the track 2 option, having said that, they have to have a history of no exacerbations while they're on their current therapy. So how is it used? So with step 1, patients use SABA and low-dose inhaled corticosteroid, or with ICS taken after the use of SABA. For steps 2 and to 5, patient takes ICS-containing controller medication on a regular basis every day, and uses SABA alone for symptom relief, kind of like your classical asthma management that is known historically. Now, the important feature to know is that when should it not be used? So you have to really think about, before prescribing the regimen with SABA reliever, is that if the patient is likely to be adherent with the prescribed inhaled corticosteroid. If they are poorly adherent, then they will be at higher risk of exacerbation. So you have to weigh both options and consider the patient's history in adherence. So why ICS formoterol? So to understand the rationale behind those decision changes, GINA no longer recommends SABA-only treatment for step 1 in adults and adolescents. And this decision was based on evidence that SABA-only treatment increases the risk of severe exacerbations, and that adding any ICS in particular significantly reduces the risk of serious exacerbations. And halfway through this lecture, we'll present some of the evidence. One thing to highlight is the terminology that has been used, mild asthma and severe asthma. So mild asthma, basically the definition remains the same. So patients who are well controlled with the reliever alone or low dose ICS, but severity cannot be assessed until patient is on treatment for several months. And severe asthma has been defined as patient remains uncontrolled despite high dose ICS LABA, or that requires high dose ICS LABA to prevent patient from being uncontrolled. One thing that I'd like to highlight, because it will just show up on the different guidelines, is that GINA does not distinguish between intermittent and mild persistent asthma. And this basically goes back to the time where it was historically an arbitrary distinction, and which causes a little bit of confusion. And now they stick to the mild, moderate, and severe asthma. Another major change that has happened was the addition of long-acting muscarinic antagonists. And this has been included as a combination ICS, LABA, and LAMA. And this is usually indicated for patients who are persistently uncontrolled despite being on ICS, LABA. And for patients who are more than 6 years of age, this doesn't come as a triple combination, so it will be an ICS LABA plus an add-on tiotropium. So this is the only medication that has been approved for use in the pediatric age group. Patients who are age for 18 years or older, then there's the multiple options of triple combinations of ICS, LABA, and LAMA. The evidence behind that, does that improves lung function but not symptoms, and this appears to be evidence A based on the grading of evidence in GINA, and that's based mostly on randomized control trials. And evidence B for a modest increase in the time to have a severe exacerbation requiring oral corticosteroids. One thing that you need to know is that before considering ICS, before considering long-acting muscarinic antagonists, you need to make sure that the patient is on at least a medium dose of ICS/LABA. One thing that also has been added was a primary prevention, so identification and correction of vitamin D insufficiency in women with asthma, because of, as you are well aware, there's an association, and that is considered as a primary prevention. Will not, bug you much with the COVID, but generally in GINA, what has been mentioned was that there's no increased risk of acquiring COVID-19 in patients with asthma. There's no increased risk of having severe COVID-19 infections in asthma as long as it's controlled, and there's no increased risk of COVID-related death, except in patients who are on recent oral corticosteroids that have been used for asthma therapy. Now, moving on, the Canadian Thoracic Society had a recent update, and this is their classical pyramid image, which is a colored zone in comparison to the step zone of the GINA guideline. And the main addition to this classical CTS diagram is the addition of either SABA or budesonide formoterol, which was previously as SABA alone. The Canadian Thoracic Society did update their definition of mild and very mild asthma, because now management does differ. So patients with very mild asthma are usually well controlled just on SABA alone. With patients who have mild asthma, they're usually controlled on low dose ICS, leukotriene receptor antagonist, and PRN asthma, or PRN budesonide formoterol, and that is your ICS formoterol combination. The risk of exacerbation was as well updated, and that steers whether the patient will need whether the patient is a candidate for a PRN ICS LABA or not. And this is something that you could go into detail and read more about. But for the purpose of time, we'll just go and talk about the treatment. So these are, I think, the more pertinent changes that have happened in the CTS guideline. So patients who are well controlled, who have a high risk of exacerbation, as previously mentioned, or patients who are well controlled but no risk of exacerbation, but prefer better control or decrease of risk of exacerbation, then the recommendation is to be on daily ICS plus PRN SABA, and that is applicable for all ages. On the other hand, the other option is to administer budesonide formoterol, that's your ICS formoterol. However, compared to GINA, the CTS includes patients aged 12 years or older. They are evaluating the younger age group, I think, in their upcoming guideline. For mild asthma, these are patients who are poorly controlled on PRN SABA. The recommendation kind of remains the same for the daily ICS and PRN SABA, or PRN budesonide formoterol is recommended over daily ICS plus PRN SABA, and that's for the 12 years and above. Control criteria, there are two parameters that have been updated, and these were regarding the daytime symptoms. So this was changed from daytime symptoms, as previously it was at 2, so now it's 2 or less, and the doses are also for 2 and less. Previously, it was less than 4 days per week of daytime symptoms, or less than 2 doses per week for fast-acting bronchodilator. Severity classification, similar to asthma, they no longer are used, and they don't really recommend their uses because of the same issue with the confusion. So now that we've highlighted the addition of ICS formoterol in one of the 2 major updates in asthma classification, what we can see is that the main highlight is that there is ICS formoterol results in severe exacerbation reduction. So this was based on one of the major publications in the New England Journal of Medicine 2018, and this was followed by the GINA guideline changes. This was a large double-blinded study where 2/3 of patients have reduced risk of severe exacerbation. Another study was an open-label study showing patients who are taking SABA alone who had reduced risk of reduction. And another study, this was in 2014 in thorax, and this showed a reduction in exercise-induced bronchoconstriction. Another outcome comparing ICS alone versus formoterol, and the outcome was assessing whether they developed severe exacerbation. This was a non-inferior study, which also showed that there was use of ICS formoterol was non-inferior to using ICS alone in prevention of severe exacerbation. And then in two different open-label randomized controlled trials, it was actually superior compared to ICS alone. So now we'll probably just whiz through this for the sake of time. This appears to be an update, but still lagging behind major pediatric asthma guidelines, and I think general guidelines. This highlighted 6 priority topics, which we'll be touching on. However, we will not be talking about the bronchial thermoplasty in adult severe asthma. Fractional exhale nitric oxide has been addressed in both the GINA and the CTS guideline on their previously. However, this has been a new update, and what they recommend is that patients with asthma, fractional exhale nitric oxide could be a useful indicator of type 2 bronchial or eosinophilic inflammation of the airway, and it might be helpful, or a good candidate is a patient who the diagnosis of asthma is being considered, and these are patients who are 5 years of old or older with uncertain diagnosis of asthma, or patients who cannot do spirometry. So this is more of a complement to your spirometry. And what you can see here is that the numbers have been shared, and that lower levels can occur in different medical conditions. More than 35 parts per billion in children between 5 and 12 years of age usually has a high sensitivity of pointing to an eosinophilic airway inflammation. Recommendations were added for indoor allergen mitigation for management of asthma. So basically, patients who have no sensitization, there does not need to be any particular need for allergen mitigation. However, what they've added was that for individuals who have symptoms worse with exposure, for instance, to indoor allergens, pests or dust mites, and Dr. Ahmed Ghodi can really add on that, is that from history taking or allergy testing or allergic specific mitigation is recommended. This can be it can vary from air filtration systems, carpet removal, impermeable pillows, HEPA filters, and so on. With management, as you can see here, the NAEPP does still use the intermittent and persistent terminology. So for patients age 0 to 4, step 1 remains to be PRN asthma. They've added the use of intermittent corticosteroids. And then in step 2 is daily low dose ICS and PRN SABA. It hasn't changed that much. So the key point here is for patients who are having recurrent wheezing defined as more than 3 episodes triggered by an apparent respiratory tract infection and no wheezing in between infection. Recommendation was to use a short course of 7 to 10 days of daily ICS, and the studies that they have looked at was the use of 1 milligram of budesonide twice daily. For patients 5 to 11 years of age, the steps remain to be the same for almost step 1 and 2. Step 3, they have added the use of maintenance and reliever therapy using ICS for formoterol. And then with steps 5, usually they've changed it to a regular dose. Now the alternatives always, remain the same. For patients 12 years or older, step 1 remains the same. Step 2, they've added either daily low dose ICS and PRN SABA, similar to what has been recommended as an track 1 or track 2 in the GINA guideline, or PRN ICS followed by SABA. And then step 3 will be the use of MART therapy. So LAMA was added as well. So it slightly differs a little bit in the GINA guideline. It has been recommended that LABA has to be there with a medium dose ICS before considering LAMA. This guideline does not really recommend that, or does not really address that. Subcutaneous immunotherapy was something that they've added for patients 12 years or older, and this is recommended as an adjunct treatment for individuals who demonstrate allergic sensitization and evidence of worsening asthma. So it's important to not initiate, increase, or administer maintenance subcutaneous immunotherapy while patients have asthma symptoms or patients with severe asthma. So just to recap the main take-home messages from those updates, what we can see is that there's a highlight or emphasis on reducing the risk of exacerbations for patients in general. But what we can tell here is that even patients with mild asthma appear to be at risk of exacerbation, and that's why there is the emphasis on utilization of inhaled corticosteroids. So this was emphasized in the use of mild asthma or intermittent asthma, except for the NAEP guideline. There was an emphasis on regular ICS formoterol or an as-needed basis or MART. And then the use of ICS formoterol did differ between the two guidelines. The CTS still recommends it. The GINA still recommends it at 6 and more. CTS still remains at more than 12, where they will be reviewing it, I think, on the next guideline. The long-acting muscarinic antagonist is unanimous among the three guidelines. However, CTS still recommends it for patients more than 12 and would review it for the patients less than 12. Asthma severity terminology, most guidelines still use the mild, moderate, severe. Still, the NAPP uses the intermittent persistent, and I'm hoping that they would move to using the mild, moderate, severe terminology. And finally, COVID-19 and asthma. Generally, patients with asthma do well and do not appear to be at high risk of acquiring or complications of death, except patients who are at high risk and have been using oral corticosteroids recently for asthma. And these are the references that you might consider. So these are the main documents. So the GINA guideline, the CTS guideline, and the focused update on asthma management. And I'd like to thank you all, and we'll be happy to get the experiences, or if someone has any questions, welcome.
Thank you very much, Dr. MajId. That was a very comprehensive review of the updates of the guidelines. I'm gonna check if there are any questions. I don't see any yet. I would start probably with the first question until we get more questions from the group. Have you started to change your practice according to the new guidelines with the use of the smart therapy?
Well, it's something that I'm trying to implement. I've recently returned. It was something that I've been doing before, particularly for patients who at the older age group who you want to get them to buy in of the use of this as a reliever, but at the same time you sneak in some corticosteroids with that use. It's really something that I found to be much more acceptable in patients who are in the older age group, who prefer to use a turbohaler, for instance, rather than use a spacer and an MDI. This becomes of an issue with the younger patients and the buy-in of the parents. But it's something that is gradually accepted in the community.
I think I agree with you. It's kind of a challenge for pediatrics because the availability we have in terms of formoterol budesonide is a turbohaler. So when the guidelines were published, I think those countries have it in the format of a meter dose inhaler, which is easier to use in a younger age group. And I think that's something we have to push to get available locally if the guidelines are pushing in that direction, because the turbohaler has its limitations, in terms of technique adequacy, that it has to be done correctly for the pediatric age group. They have to do it correctly. So that's the challenge, I think.
Yes, and then I think so. What I've been previously doing was, it's mostly this the budesonide formoterol combination. But now here I found out that there is a another formoterol inhaled corticosteroid combination comes in and an MDI in here. I don't want to use particular brands out here. So there have been, I think, some MDI, but it's not your classical turbohaler company.
Okay. No, I agree with you. There are other formulations that are becoming more available, but not always readily available. But I think this will be the opportunity for the pharmaceutical companies to start in that line, I mean, because the guidelines have been shifting. Now, I have a question here. Triple formoterol beclolama, can it be used below 18 years or similar to Trilogy?
So far, as you see, the guideline doesn't recommend the use of triple. It's the triple therapy is licensed or approved for patients 18 years or older, and our adult colleagues probably have much more experience. I've never used a triple therapy except for patients who have been very uncontrolled, and that doesn't come as a one device combination. It's rather ICS LABA plus an add-on tiotropium for patients 6 years or above. Mm-hmm. But it'd be interesting to see if someone else has, an experience with
the severity we have here locally is a little bit different. We rarely face the severe cases similar to the Western countries. And I think, because of the age as well, we don't, typically those severe cases will be above, I think 16 or so.
Oh, 16, yes. That's right.
And that's why we probably were limited with this. I mean, we don't see the severe cases. Maybe that has limited us. And I don't see any other question yet. I will encourage the participant, please, to submit your questions if you have. The other thing that the national guidelines, I mean, they went through the checklist of the environmental triggers, and everything didn't show any good evidence as well. So that's another thing that I don't know how we advocate that with the parents. We typically ask the questions, do you get exposure to dust and all of that? And they will always ask you about the vacuum and whether they go ahead and purchase that special vacuum. So what would be your typical answer now?
Can you formulate that in a question, or maybe rephrase that question?
Sure. When you reviewed when the NAAP, they reviewed the guidelines for the environmental control, whether dusting your carpet or whether putting a humidifier and all of that will make a difference, and it didn't show any difference, right? Mm-hmm. So now we're facing from a clinical perspective, you may face that with a family asking you, we're going to purchase that humidifier to control the asthma. So what would be a typical answer we should give them now after the evidence have been reviewed that didn't show much?
Really, I mean, if from a clinical point of view, the evidence is there. But at the same time, if some parents seem to be adamant in getting those things and maybe feeling a little bit content that they're doing something, why not? That's something that they could choose to go ahead with. However, it's always a question whether it makes a difference or not, and maybe from one patient to another there might be some difference. And I usually, have a kind of a family-centered decision rather than make my own decision, particularly when it comes to that.
Mm-hmm. That's true. We have a couple of questions now popping up. It's about immunotherapy. Do you think it's effective for asthmatic patients? If you can share your advice to be used or not?
Well, I'm not the expert when it comes to immunotherapy. You have two experts here when it comes to immunotherapy. I personally, I'm early in my career, and I haven't used immunotherapy for patients with asthma.
Okay, fair enough. I think we'll defer those to Dr. Ahmed in his talk. We can talk about immunotherapy. Thank you very much, Dr. Majid. That was wonderful. You did an extensive review of a difficult guidelines. Asthma in children is quite tricky, and that was wonderful. Thank you very much.